Bismillah ar-Rahman ar-Rahim. Dear all, welcome to the episode 1 or lecture 1 from our series about nephropathology. It's my pleasure and honor to have Dr. Sarah Hassan, Associate Professor of Pathology and Electron Microscopy, Theodore Belharz Research Institute in Egypt. She is one of the eminent pathologists actually in Egypt. She will start to deliver to us different episodes over the coming months to cover pathology, nephropathology from A to Z, from A to Z, from the basics and from the terminology and alphabetics of pathology, nephropathology, till the advanced glomerular nephritis and vascular diseases affecting the kidney. Please interact with Dr. Sarah through the chat box if she asked any question. And also, if you have any question to Dr. Sarah, please write it in the chat box and I will deliver it to her. Please, Dr. Sarah, the floor is yours.
Good afternoon, good evening, everybody. It's my honor to share with you Dr. Muhammad today, and I hope you enjoy more than to learn nephropathology. And let's start. Our agenda will include a revision for normal renal histology, point by point, under both light and electron microscope. Every colored picture, so it's for a light microscopic examination, and every black and white is for an electron microscopic examination. Just not to mention that this is a light microscopic micrograph, or it's an electron microscopic image. The color is of light, and the black and white is for EM. But we will have multiple stops. Our lecture will not be only for the normal renal histology, but every now and then we will stop to compare histology with its counterpart, which is its pathology, just to be more light and more joyful for our talk. And throughout our journey, we will revise some definitions as well. And remember that every morphology has an underlying why, which is the pathogenesis, and that reflects on its nomenclature and definition, and that's a lovely science of histopathology. First, that's the normal glomerulus histology, and as we mentioned that this is a colored picture, so this is a light microscopic picture. This is a Mason trichrome stain. It's not our scope for today to talk about different stains, but this is a Mason trichrome. And the normal glomerulus means that we should see just an empty capillary lumen and an empty urinary space, as highlighted by the red arrow and the red dots for the empty capillary lumen. That's the main issue that will take your eyes or take your attention to see that, okay, it's a normal glomerulus, it's empty. Then parietal epithelial cells with the black arrow, the visceral epithelial cells or the podocytes, the famous podocytes, we can see them under light microscope, but actually only their nucleus. That's the red arrow, and the endothelium, also its nucleus, the orange arrow. As you can see, it's
Sarah,
just one.
Can I ask you a question here?
Okay.
Can you point for one of the podocytes that is not on the periphery?
One of the podocytes that not on the periphery.
Yes.
Actually, maybe this one.
Okay.
Maybe this one.
How you know that this is one podocyte and is not an endothelial cell?
Endothelial cell should be bulging inside a capillary lumen. So that's a capillary lumen, and something is bulging inside. That's the nucleus. But the podocytes are bulging outside. So it's not actually it's not the right way to pick up a podocyte
mm,
in the center.
okay,
Okay, we usually try, and we all try to pick up everything at the periphery.
okay,
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 not in the center, not in the center, and not near the hilum. That's the hilum.
okay.
That's the capillary inlet
Mm,
of the glomerulus.
mm,
So try to be away from the hilum and from the center. Try to be looking for the podocytes at the periphery. Try to look for the glomerular basement membrane at the periphery, and so on.
okay, thank you.
Okay, I'm clear.
Yeah, yes, very clear. Please continue.
Okay, let's complete. That's the EM, the electron microscopic picture of a segment. It's not a whole glomerulus as we saw in the light microscopic picture, because this is at least 3,000 times magnification for the past picture. So we are just seeing one capillary of the glomerular tuft. Now we will highlight at the bigger image of the electron microscope what is the parietal epithelial cell, again the black arrow. What is the visceral epithelial cell, the podocyte, the nucleus, we can now see it very clear, the red arrow, and the endothelium nucleus with the orange arrow. So it's now loud and clear when we compare this to that. Okay, where's the
Sarah, I
messenger?
want to ask
Mm,
you a question, please.
mm, mhm,
Is it always
mm,
the situation that the podocyte nucleus is
mm.
larger than the endothelial nucleus, or this is not always the situation?
Actually, according to the cut, we can imagine that any nucleus is like a ball.
Mm,
So, if you cut at the periphery of the ball, it
mm,
is a of a small circumference, small
okay,
diameter.
okay,
And if you are nearer to the center, you will have a bigger diameter, and
yes,
so on.
okay,
But generally speaking, the podocyte is bigger than the endothelium.
okay, okay,
Okay, actually, I don't have round figures or round number to say that this its diameter is actually a number, but generally speaking, the podocytes are bigger than the nucleus.
okay.
Okay, so we can now appreciate where's the mesangium, where is the capillary lumen, where is the endothelium, where is the podocytes nucleus, and where is the parietal epithelial cells. Let's continue. The endothelium is not just a nucleus. Any cell is composed of a nucleus and a cytoplasm. The cytoplasm of the endothelium is lining the glomerular basement membrane. And here these are highlighted with the orange arrows. That's what? That's the endothelial cytoplasm. It is a thin layer line the inner surface of the glomerular basement membrane, and it is fenestrated. This means that it's a thin layer of cytoplasm with pores every length. Every length there is a pores. Higher magnification will show us this fenestry. Are these fenestry are clear for you? It's a thin layer inside the capillary lumen, thin layer of cytoplasm with pores in between. Okay,
So,
the
so,
podocytes.
so when we say that
Hmm,
there are subendothelial deposits,
mhm,
actually you mean that some of these deposits or most of
mhm.
these deposits are sub the endothelial cytoplasm, right?
Right,
Okay.
or even its nucleus,
Yes, or even
whatever,
yes.
whatever. Okay, so the podocytes are on one side and the endothelium are on the
Please, Sarah,
other side.
please,
Mm,
Sarah,
mm.
use the cursor
Okay,
about you are talking.
that's the glomerular basement membrane. Okay, the cytoplasm are shared for with the black arrows. That's the cytoplasm. The thin fenestrated layer of cytoplasm with the pores. These are the pores. Fenestry or pore. Pore here, pore here, pore here, pore here. Okay? I think these are clear. And that's the capillary lumen. That's the glomerular basement membrane. On the other side, these are the podocyte. The podocyte nucleus, that's the nucleus. And these are the podocyte food processes. We all hear about the podocyte food processes or the podocytes. These are food processes and they are actually like food processes, and they are covering the glomerular basement membrane on the urinary surface or the urinary space of the glomerular basement membrane. Okay? And that these podocytes are of normal appearance and have their podocyte like configuration. This diagram will show us in a diagrammatic way the side of the nucleus of the endothelium and its fenestrated cytoplasm that lines the glomerular basement membrane from inside the capillary lumen. The glomerular basement membrane and the podocytes are outside in the urinary space. The mesangium is in the center between every group of capillaries of the glomerular tuft. And the podocyte nucleus is here, from which the podocyte cytoplasm comes out, making the podocytes food processes on the outer surface of the glomerular basement membrane. So now the first thing that we said was that the glomerular capillaries should be empty. What if the capillary lumen becomes narrowed or occluded by cells? These cells could be just proliferation of the resident cells, which are the endothelial cells. Or these resident cells did not proliferate but just injured, which will cause that the cytoplasm, the thin layer of the cytoplasm that we have seen, when these will are injured, they will be ballooned. So they will fill the lumen of the glomerular capillary. The other situation is an outside intruder cells goes inside the glomerular capillary, which these cells are mostly inflammatory cells. So these are not resident cells, they are intruders or inflammatory cells. Let's discuss the first situation
Sarah,
where the...
can I ask a question regarding situation 2? Can you put it again on the slide?
Situation 2.
Yes, you in situation 2, you mean the cells from outside the capillary lumen will invade the capillary lumen, right? Okay.
I mean cells, inflammatory cells.
Yes.
They should not be present here in a large number.
Okay, you said that there is increased number of mesangial, endothelial, and infiltrating inflammatory cells.
Yes. I am trying to simplify this.
Yes, regarding this endothelial term, which endothelial cells?
The cells that we were talking about, these endothelial cells.
So you mean in the second option? Okay, in the second option, you mean there is a proliferation of the endothelial cells, and there is invasion from other sides, invasion of other cells from outside, right?
Yes.
So, yes.
Endothelial cells will proliferate in both situations.
Okay.
The main difference is the intruders, the inflammatory cells.
So
that's the main difference.
Yes. So the endothelial cells in second option are the endothelial cells of the capillary that are present in first option, right?
Again, please, Dr. Muhammad.
The endothelial cells in option 2 are the same as endothelial cells in option 1.
Yes. The difference is that in situation 1, these are just an injured endothelium. Just an injured endothelium. Okay? So let's compare between the capillaries in this glomerulus, the upper capillaries, the upper left capillaries with the lower right capillaries. What can we say about these two group of capillaries? The upper ones are mostly what? Mostly? Any answers?
You can answer in the chat box, dear colleagues. What do you see? The upper left tuft inside the red circle. Is it empty or closed? They answered it is open and normal, empty. Thank you.
Okay.
Mm.
And the lower group are mostly occluded.
Yes,
Mostly occluded. Some are empty, some are empty. That's empty, that's empty. But this part is occluded,
yes,
right?
yes.
Okay, so these are occluded. Our job now is to say, is it occluded by cells that are of situation number one, just endothelial injury, or there are intruders, there are inflammatory cells.
Mm.
Let's try to differentiate. This light microscopic picture is not labeled. So I would like to say your impression about this picture. Is it empty or occluded, or empty or occluded? Is it normal or occluded capillary lumen?
Please answer in the chat box. We have first answer, it is mixed. So we have
Mm.
some open and some
Mixed.
closed. Yes.
That's right.
Some are
Mm.
occluded.
Mm.
Some
Mm.
are answered as occluded. Uh,
Okay. Okay. It's mixed, right? It's mixed.
yes.
It's segmental occlusion, right? But with which type of cells?
Mm.
Can you appreciate the arrows? These are sharing or highlighting a type of nucleus. This nucleus, I'd like to describe them. Can you describe these nuclei? These
Uh,
nuclei, I'll describe them. These nuclei are big or large with light color. Light color. I know that you can be not able to say that these are big and light colored because you don't have a counterpart to compare with. Am I right, Dr. Muhammad?
yes, sir.
Okay. Just keep this picture in your mind that these nuclei are large and of light color.
Okay.
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 Another picture, and I would like you to say the segment of the capillaries in the black circle are occluded or empty.
It is occluded.
It is occluded, right? By cells or by I mean by nuclei mainly, or something else.
I will them to answer.
Hmm?
Yeah. We have cells, nuclei,
Nuclei. We have nuclei or something else.
or some. Most of
Hmm.
the answers are going with nuclei,
No, that's
and we
nucleus.
have something else finally.
That's nucleus. The nucleus is of that color. It's rounded and of blue color. That's the nucleus. The surrounding something else is a cytoplasm, is its cytoplasm, which is normally are not seen in light microscope because they are normally thin, as we said. Here, that's the cytoplasm. The cytoplasm here is ballooned, is big and occluded the capillary lumen. Why? Because it is injured.
Mm.
Okay?
Mm. Yes, clear.
This circle is for a an arteriole. Okay?
Mm.
This arteriole has an occluded or empty lumen.
It is clear to be occluded.
It is occluded.
Mm.
Okay. Can you appreciate the nucleus? That's a nucleus.
Mm.
It is surrounded by something which is its ballooned cytoplasm, or plus some, but plus other things. It is a We will talk in details later on, but I would like to say that not every occlusion is a proliferation of nuclei. It could be a just an injured cytoplasm. Okay,
mm,
that's an electron micrograph to show us the occluded capillary lumen by the injured endothelium. That's the nucleus of the endothelium, and the nucleus of the endothelium, and that's the glomerular basement membrane, and the podocytes here outside are effaced. They are not of food process structure anymore here.
mm,
Maybe here they have still have the podocyte finger-like projections, but here they are effaced. So the glomerular basement membrane, where is the endothelium? Where is the fenestrated thin layer of the endothelium? Can anyone see it?
no, not clear at all.
It's not here, or it's there. It's all
Mm,
this layer that was thin and fenestrated. When it's injured, it becomes ballooned like that
mm,
and fill the lumen. All of this area is the ballooned and injured endothelium.
mm.
Okay?
Okay.
So that's situation one. I hope that the idea is clear for you. We didn't talk about when this occur, but I just want to deliver you a message that that occlusion could be. Hmm.
Situation one, is there a terminology explaining situation one? As in situation two, you will call it endocapillary hypercellularity. In situation one,
Hmm.
is there a terminology or a name for it?
It's just an endothelial injury. If we will put it under a big known terminology, it
Mm,
will be under the terminology of TMA or thrombotic microangiopathy.
mm.
Uh, yeah, I didn't
You
want to talk about it
yes.
now. We will talk about it later on, because it's not the classic TMA that everyone thinks that you will see endothelial injury thrombi, and it's not that
Okay.
strict or that one way idea. It's just the start of team A. The start of team A is just like this pathogenesis. It's an endothelial injury. So
Yes.
endothelial injury, this can occur with accelerated phase of hypertension,
Mm,
with TMA secondary to any autoimmune disease,
mm,
with TMA of complement mediated disorders.
mm.
All of these disorders can cause endothelial injury that will be seen like that.
Okay, great.
Okay, so that's one way of thinking. The other way is the endocapillary hypercellularity of or proliferation with the intruders, as
Mm,
we have said, plus in endothelium. Endothelial cells are very sensitive cells. They could be injured by so different means. Any insult can cause an endothelial injury. Okay,
okay.
of course with different grades. What we have seen is a severe grade of endothelial injury, but actually you should see the severe end of the spectrum just to appreciate it. Okay, as a start, I would like to highlight something else, that the mesangium and the endothelium are considered one compartment, which is the endocapillary compartment.
Could you repeat, please?
The mesangium and the endothelium are considered as one compartment, which
Mm,
is the endocapillary compartment. What does this mean? That's why I am underlying the word mesangium. Let's be back to an electron microscopic picture of the glomerular tuft. Okay,
mm,
here is the mesangium. Okay,
mm,
and that's the endothelial nucleus,
mm.
and that's what the mesangial
Messenger.
nucleus.
Yes.
Okay, can you appreciate here the glomerular basement membrane? The glomerular basement membrane is continuous here, or it goes like that to separate the capillary lumen from the mesangium? It's just continue like that, right?
Yes, you mean that it is encircling the mesangial cell.
Yes, yes, that's the encircling, or this area we call it the hinge region,
Mm.
where the glomerular basement membrane reflects on the mesangial area. So the capillary lumen is just
Sarah,
in.
can you
Mm,
go with the full capillary basement membrane by the cursor?
okay, that's the glomerular capillary basement membrane.
Okay,
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 okay, let's go with it. Let's go with it. Let's go with it. Let's go with it. Here we are in the mesangium.
okay. Then can you
Then
continue?
uh, up again, up again, up again, up again. We are here. We are in a glomerular basement membrane.
Okay.
So
So
it's
it covers
continuous here.
part of the mesangium, not all the
Hmm?
mesangium. It covers a part of the mesangium, not all the
Yes, yeah,
mesangium.
not all the mesangium.
Okay.
So here is the endocapillary, or the capillary lumen, endocapillary compartment, or the capillary lumen. The endothelium here, that's an endothelium, is in direct continuity with what?
With the
With the
mesangium. Yes.
mesangium,
Yes.
right?
Right.
So the mesangium and the capillary endothelium are just one compartment facing the capillary lumen, facing the bloodstream.
Mm.
It's why they are one compartment, because both are facing the bloodstream
Okay.
with no boundaries between the mesangium and the bloodstream. It is
Mm.
just the fenestrated endothelium. Also, there is no basement membrane to hide the mesangial area from the bloodstream. But it may be the first site where the immune complex deposits go is the mesangium before going to the subendothelium, because this area is in direct contact with the bloodstream.
Mm.
Okay.
And that's why mesangial deposits cause hematuria, right?
Actually, I don't know. I didn't read about this pathogenesis before.
Okay.
But the issue is when I knew that this is a same compartment, this is the same compartment. This made me find that the idea of endocapillary proliferation. Why in endocapillary proliferation I found mesangial proliferation like in post-infectious GN? Why is the mesangial proliferate?
Mm.
Because it's just one of the same compartment.
Okay. We have
Okay,
a question in the chat. Can you highlight endothelium nucleus in this picture?
That's the endothelium nucleus.
Okay.
Actually, we should have just one or two endothelial cell nuclei in one glomerular capillary.
Okay.
Okay, and a maximum of three mesangial nuclei in a single mesangial area. Okay,
Okay.
I highlighted it. Okay, so one mesangial nucleus, one, two, three, and one endothelial nucleus, one. Okay,
Okay, great.
okay. Let's continue to the concept number two, where we will have intruders. Okay, so these capillary lumina are occluded or empty. Actually, I write it. These are occluded, but the nature of the occluding nuclei. Can you now appreciate the difference between these nuclei and the past nuclei? The nuclei that we saw in the picture of the endothelial injury were large and of light color. These nuclei are smaller and of darker color. Can you appreciate this difference?
Yes, it's clear.
Okay. One of the cells that we like to see is the neutrophils. Can you see this nucleus?
Can you describe it?
This nucleus is segmented. Segmented means what? It has segments, one, two, three. And this nucleus also segmented, one, two, three. Clear?
Yes, for me it's clear. It's clear for all of you. If it is not clear, please tell us in the chat box. Yes, it's clear, sir.
Okay. These are neutrophils. So these are inflammatory cells that are different, totally different from the injured endothelial cells. Okay. Again, an EM picture. Can you see the difference between these cells and the resident injured endothelial cells? These cells have what? Have a darker, smaller nucleus again. Its cytoplasm is smaller, but it has these black dots.
Mm.
These are the lysosomes
Mm.
that they use to uh, um, get their proteolytic enzymes and induce the inflammatory reaction and so on in the pathogenesis of the diseases. Okay, these cells are inside the capillary lumen. This is the remaining part of the empty lumen of the lumen occluded now, and this is the remaining empty area in the capillaries.
S-
Okay,
uh,
it's clear. Mm.
yes, all of these, you said that the cell on the top right is neutrophil. You said that on the
No,
top
I
right.
don't say. It's mostly neutrophil, but the segmented nucleus is not here in this cut. But that's the segmented nucleus.
This is uh,
This is
a
a neutrophil.
lysosome, neutrophil
This
lysosome.
is neutrophil. لا, that's its nucleus. That's the nucleus.
Okay,
Segmented nucleus.
okay,
Segmented nucleus means it has this nucleus has segments, multiple segments. When we have a cut in it, it will appear as if it is two nuclei, but actually they are connected to each other at somewhere. But we did not pick up it in this cut. Okay,
okay.
this is its cytoplasm full of lysosomes.
Yes.
Okay.
Can you catch? We have a question. Kindly explain disease-wise. I cannot get the question. Can you compare between both cells in one slide? Which two cells, Dr.
Mm,
Khalid? He mean which two cells? Endothelial and
endothelial and inflammatory.
in this slide there is any endothelial cells, Sarah?
No, these are mainly inflammatory cells. Okay, keep this in your mind. Okay,
Okay.
and just see this.
Okay.
These are
I
injured
want
endothelial
to
cells.
say that an important point Sarah mentioned at the beginning of the lecture. We are not now searching for a specific disease. We
Mhm.
are only talking about terminologies, whatever the disease
Yes,
in the electron microscopy or light microscopy. Then
yes.
the later
Just
lectures, inshallah, we will talk about the diseases.
inshallah. Okay. These are injured endothelium. Okay.
Mm,
The nucleus here is big and light colored. Okay.
mm,
Let's compare with this. The nucleus here is small and dark colored,
mm,
or segmented of the neutrophil, or very dark, very dark,
mm.
very dark. Okay. Back to the endothelium, large nucleus and light colored. I think it's obvious,
Yeah,
right?
it's clear now.
It's clear.
I think yes, Dr.
This
Khalid, it's clear, Dr. Khalid. Yes, it's clear. Yes, you can continue.
I want to say something that it's not always that clear for me. It's not always that clear. We can get
I
confused.
know that you selected the most clear photos for us.
Uh, Actually, it's not. It's usually clear to differentiate between this, but I say that sometimes it's not that clear. But
Okay.
usually it's clear. Usually it's clear. But sometimes you can get lost. What is this? Is it an inflammatory cell or is it something else? Okay.
Mm,
But usually, actually, it's clear. No, it's not. These are not the most clear pictures I have. No, but I just want to say that because if we have colleagues of nephropathology, sometimes we get lost sometimes.
mm.
Okay, let's continue.
Sarah, excuse me. Can you go back rapidly for the image where the endothelial cells were large and light, have a light color?
Um, This picture?
No, no, the light microscopy.
Light,
Yes.
light.
I'm sorry.
This one or
No, no. Back again.
this one?
Yes. You said
Mm.
that here there is an endothelial injury, right?
Mm, 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 mm,
But the endothelial injury here in the form of just a swollen endothelial cell. There is
mm.
no expansion of the cytoplasm, and there is no exclusion. Full occlusion of the capillary lumen, or there is occlusion of capillary
Actually,
lumen.
the cytoplasm is ballooned.
Is
You can
ballooned.
appreciate. You can appreciate here. Something here is ballooned.
Can you point for other areas where the cytoplasm is ballooned?
Actually, this glomerulus has ballooning everywhere. You cannot appreciate here that there is a there is a mesangial area that is
Expanded.
even the mesangium here. Do you know the term mesangiolysis?
Yes.
Mesangiolysis, it's one of the most difficult terms that I spent a lot of time just to imagine what is this.
Yes.
It's just like that. It's just ballooning.
Let is with the team A later.
Yes,
Okay.
it's just like that. Everything is ballooned. Everything is ballooned.
Okay.
Okay.
Regarding Dr. J, explain like examples, please, so it will be easy and memorable. You like examples like diseases causing these abnormalities? You can continue till he answer or she answer, sir.
Okay.
Okay.
Like one of the most important disorders where endocapillary proliferation or hypercellularity occurs is lupus. Of course, lupus class 3 and 4, which are strongly related to patients' mortality and morbidity. Lupus nephritis, the International Society of Nephrology and the Renal Pathology Society changed the terminology in 2018 from endocapillary proliferation in class 3 and 4 into endocapillary hypercellularity. What's the difference? The difference is the increase in the intracapillary cellularity is primarily due to infiltrating leukocytes that we call the intruders, rather than proliferation of endogenous cells, which are the endothelium, and the mesangial cells, which are the same compartment as we said. So they changed the terminology from proliferation, which means the resident cells increase in number, into hypercellularity. So we should have intruders. And this paper was discussing the use of CD68 positive cells as a surrogate marker for endocapillary hypercellularity in lupus nephritis. The researchers in this paper were discussing a problem. What was their problem? That there is an inter-observer agreement which is of a moderate grade in recognizing the endocapillary hypercellularity. This moderate grade of inter-observer agreement, they considered it as a low grade. So I may say this is an endocapillary proliferation. Another colleague may say that this is an endocapillary hypercellularity. Okay, who can say that which of us is who of us is the right one? It's just what I say and what he said. So we should have a marker. This marker is important in cases of lupus activity. That means that the patient need to receive more aggressive immune suppressants if he has the proliferation, and that will classify him as class 3 or 4. Okay, so they emphasized on the importance of endocapillary hypercellularity rather than proliferation in lupus nephritis. And they suggested that the definition of endocapillary hypercellularity is critical for critical cause for the inter-observer variation. Therefore, the definition was modified in the revised International Society of Nephrology classification, and they stated that the influx of inflammatory cell is the most important component of endocapillary hypercellularity, and that if an intracapillary lesion has no inflammatory cells but only consistent of endothelial swelling, this lesion should not be regarded as endocapillary hypercellularity. Okay?
Sorry, sir. You said that,
Mm.
and if an intracapillary lesion has no inflammatory cells, intracapillary lesion may mean uh,
Intracapillary proliferation.
endothelial, endothelial and mesangial, right?
Let's talk about endocapillary. Let's talk about endocapillary only.
Yes, I want you to explain it more. You said that, and that if an intracapillary lesion has no inflammatory cells, what
Mm.
do you mean exactly by intracapillary lesion?
Endocapillary proliferation, endocapillary hypercellularity, the endocapillary away from the mesangial area.
Okay, but if no inflammatory cells,
Mm.
so
This
the
will not be regarded as an endocapillary
okay,
hypercellularity.
okay, okay,
We
okay.
all know that endocapillary hypercellularity is one of the activity index parameters of lupus class 3 and 4.
Mm, okay,
Okay, so here they said that if it's not including an inflammatory cells, this will not be regarded as hypercellularity.
okay,
Okay,
mm,
this will be regarded just as an endothelial injury.
okay.
So they used CD68, which is a marker that show us monocytes, that label monocytes, which were found to be the most important inflammatory constituent in endocapillary hypercellularity in lupus nephritis and other disorders as IgA nephropathy. Okay? So researchers of this paper found that CD68 positive cells as a surrogate marker for endocapillary hypercellularity is helpful in decreasing the inter-observer variation in recognizing endocapillary hypercellularity of lupus nephritis active classes, which are 3 and 4. So if we have a picture and we cannot differentiate, is it the first concept of just an endothelial injury, or these are inflammatory cells, mainly monocytes, which are CD68 positive. We will use this marker to differentiate. Okay. Let's back to normal histology. Any questions?
We have which please can the questions and comments come at the end of the lecture instead. It is very difficult to make the questions at the end of the lecture because we will forget which slide we have to go back to go back. We have a question from Dr. Amr Helmi. CD68 marker, is it available, Sarah, now in Egyptian
Yes,
market
of
or
course.
not yet?
Oh, it's available.
It's
It's
available.
available.
Do-
But
Mm,
I would like to say something.
mm.
Yeah, don't order for it as a routine marker because it's not always that difficult for the pathologist to differentiate. It's not one of the routine panels that we should do.
So
It's
the
just mm,
so the pathologist himself or herself should decide whether to use it or not, right?
I think yes, for all of the immunohistochemical panel, we should decide what to do.
Okay.
I think that because actually the pathologist is the one who examines the slides, and he can say to himself, okay, this could be something or another thing. You know what I mean.
Yes. We have a question from Dr. Safa. So case one, endocapillary proliferation, case two, hypercellularity. Dr. Safa, can you explain more which slide was you referring to? We have another question. Is it required to do CD69 to say endocapillary proliferation or cellularity? I think you answered this question now.
68.
Yes.
68. Hmm.
Yes. The last question is, then you can go back to normal histology. CD68 in lupus versus IgA.
It's not.
Okay.
I think you should ask the question in another way. Uh, Actually, IgA nephropathy or IgA GN is one of the disorders where we have so many of our definitions from the definitions of the IgA nephropathy. They use CD68 to recognize the monocytes in cases of IgA GN, and similarly, the same situation was done in lupus cases.
Okay.
Okay, so
We
CD68 is not is not a marker of a disease. It's a
It's not a
marker.
specific.
No, it's marker that label the CD68 positive cells, which are the monocytes, which are inflammatory cells. It's not a marker of a disease, it's a marker of a cell.
Okay, last question. Sorry for that. So, if there is endothelial injury, not endothelial hypercellularity, lupus not diagnosed?
First of all, lupus is not an histopathologic diagnosis.
Okay,
Lupus is a clinical diagnosis, okay?
okay.
And CD68 is not of the routine panel of lupus nephritis. Again,
Mm,
CD68 is not a marker of to diagnose lupus nephritis. It's just a paper that was facing a problem with the inter-observer variation in recognizing just an endothelial injury that may occur in a case of lupus that has an attack of hypertension for any cause, and she's now in an attack of TMA, okay, and no lupus activity.
mm,
Let's share with you that these clinical scenarios that may occur in your clinics. You have a patient, non-lupus patient,
mm,
and she presented to you with hypertension and elevated kidney functions. Okay,
mm,
this patient had a renal biopsy. So this patient may have an activity, or it could be just a TMA secondary to the accelerated phase of the hypertension, and there is no activity.
mm,
So the endothelial injury will be found in the case of TMA.
mm,
Signs of activity, including endocapillary proliferation, will be found if there is an actual activity of this case, including the subendothelial deposits, including the hyaline thrombi, including the inflammatory cells with the neutrophils, including the crescents, including the fibrinoid necrosis. It's
mm.
not all. It's not only an endocapillary proliferation. There is an activity in these. Okay, so if a pathologist have a problem in recognizing endocapillary hypercellularity and inflammatory cells versus an endothelial injury, this pathologist in this situation can use CD68 to differentiate between this cell from that cell.
Okay, it is very clear.
Okay.
Yes,
Mm.
please continue.
Back to the normal glomerulus histology. The glomerular basement membrane is just like a sharpened pencil tip. Sharpened pencil tip that will draw a thin line. This thin line is the glomerular basement membrane. Uh, Again, we can compare the normal thickness of the glomerular basement membrane with the tubular basement membrane. Both have the same thickness, and we can compare this as an internal control if we would like to say that this is normal. This glomerular basement membrane is of normal thickening. The mesangium in the glomerulus, the normal glomerulus, is inconspicuous. What's meant by inconspicuous? Inconspicuous is you cannot see it clearly. This means this is the meaning of inconspicuous. That's why I didn't label it, because normally we should not see a prominent mesangial matrix. Okay, so it's inconspicuous. This means that nearly the capillary the capillaries of the glomerular tuft are nearly back to back. Okay, let's discuss the glomerular basement membrane composition. What the glomerular basement membrane is formed of. As we have said, that's the glomerular lumen, that's the endothelium, the fenestrated thin layer of the endothelium, and that's podocytes. Here, the podocytes are effaced. In another lecture, we will talk about effacement and what's meant by effacement. But uh, uh, right now, you have seen what the podocytes, the finger-like projections of the podocyte. Here, you cannot see these finger-like projections. So this is absent. They are absent and replaced by this continuous layer of cytoplasm. Actually, I said what's effacement, and this is the podocyte effaced processes. In between, this is the glomerular basement membrane. It is composed of what? It is composed of three layers: an inner or middle, an middle layer, which is the main layer and called the lamina densa, and an outer thin layer, which is the lamina rara externa, and an inner thin layer, which is the lamina rara interna. Okay, so the glomerular basement membrane, it's not just a single layer, it's made of three layers. Okay. Uh, as I mentioned, the lamina rara interna is the electron-lucent layer or line. It's just the line, the thin line, immediately adjacent to the endothelium. And I hope you remember that it's not. It's just a line. It's just the line, and it is. It is a potential space. What's meant by a potential space? That it's actually a line, but if anything deposited subendothelially, this space will increase in size and will have what is deposited inside it. This deposit could be an immune complex deposit, it could be plasma proteins in cases of endothelial injury and TMA, anything. So this space or line is a potential space. The main layer is the lamina densa, and the outer line, again line, is the lamina rara extern. The lamina densa is a fibrillar-like construction, and if any of you is a nephropathologist and is examining electron microscopic cases, or cases with the electron microscope, please don't confuse this with the lamellation uh, uh, of Alport syndrome or something like that. This membrane is normal, is just normal. It's fibrillar like, and there is a difference between fibrillar and lamellation. Later on, when we will discuss Alport, you will see the actual meaning of lamellation, and we should say that sometimes it's difficult to say that it's lamellated, and because disease like Alport syndrome is is a progressing disease, and we may have pictures that is not conclusive of Alport, and a follow-up biopsy may be required to have a conclusive diagnosis. Lamina densa is made up of what? Of the famous collagen 4, collagen 4 alpha chains. Actually, the diagram shows us that it is formed of a triple helix of collagen chain, which are formed of, first, if it is a glomerular basement membrane of an embryonal glomerular basement membrane, it will be formed of alpha chains 1, 1, and 2. So 2 of alpha chain of collagen 4 alpha chain 1, and 1 of the collagen alpha chain 2. Then when the glomerular basement membrane becomes mature, it will be formed of a mixed collagen 4 alpha chains 3, 4, and 5. So it changes from 1, 1, 2 to 3, 4, 5. Collagen alpha chains are of 6 types. Again, in the glomerular basement membrane, when it's embryonal, it will be formed of 1, 1, 2. Mature, it will be formed of 3, 4, 5. I would like you to compare between the two pictures, the normal one, the left one, and compare the lamina densa in the left picture, which has a collagen 4 defect. You can appreciate that the lamina densa is markedly thinned. Here it measures only 86.9 nanometers, which is far less than the normal thickness of an adult person, which should be around 300 nanometers. So that's the collagen 4 alpha chain defect of thin basement membrane disease. What about the rest of collagen 4 in the glomerular tuft. It is present also in the Bowman capsule, but it's not collagen 4 alpha chain 3, 4, and 5 of glomerular basement membrane, but we will find collagen 4 alpha chains 1, 2, 5, and 6. The tubular basement membrane also has collagen 4 alpha chain 1, 2, 5, and 6. Let's go to the mesangial matrix, which we said that it is continuous with the glomerular basement membrane. It is formed of collagen 4 alpha chain also, but collagen 4 alpha chain 1 and 2, which is continuous with the inner aspect of the glomerular basement membrane, subendothelially, only subendothelially, but the rest of the glomerular basement membrane is formed of collagen 4 alpha chain 3, 4, and 5. Why all these details? All these details are essential and extremely important because mutations in the genes of these subtypes are responsible for the various forms of the membrane related hereditary nephritis. And the structural abnormalities of the glomerular basement membrane in hereditary nephritis are caused by the absence of collagen 4 alpha chains 3, 4, and 5. And because of their absence, the membrane fails to form correctly. Good Bescher syndrome also target the collagen 4 alpha chain 3 subtype. So why all these details? Because we should know that Alport syndrome or hereditary nephritis, what was thought a rare disease, proved to be the second most prevalent genetic cause of kidney failure behind the autosomal dominant polycystic kidney disease, affecting at least 1 in 5,000 people. And this is a study was published in 2023. Okay, Dr. Muhammad, I'm clear?
Yes, very clear. And
Okay.
the point you mentioned now is very
Mm.
important. And I think when you talk about Alport syndrome, you will talk that it is
Mm.
much diagnosed now at more than the past. And that thin membrane
Yes,
disease now is a part of
yes.
Alport syndrome. We have no nowadays disease, a separate disease called
Mm.
the thin membrane disease.
Yes, yes. You are totally right. And Alport syndrome caused by mutations in alpha chain 3, 4, and 5, which are crucial for the glomerular basement membrane consistency, results in defects defect in these chain in these alpha chains cause hematuria as well as proteinuria. And we should know that that proteinuria could be present in absence of hematuria. And I think our colleagues in nephrology knows that many patients now presents with proteinuria with no history of hematuria, at least no history of gross hematuria. Alport syndrome, what was thought a rare disease, was considered also mainly as an X-linked inherited disorder. However, based on the proposed reclassification of Alport syndrome classification working group autosomal dominant Alport syndrome, which was long believed to account roughly 5% of Alport cases, the use of the next generation sequencing techniques resulted in estimates ranging approximately from 4 to 6 times that percentage. And heterogeneous variants of collagen 4 alpha chain 3 or 4 are extremely common, affecting more than 1% of most populations. However, it could be underdiagnosed clinically because actually it presents with many phenotypes clinically. Again, as Dr. Muhammad mentioned, thin basement membrane disease has been included in the genetic diseases of type 4 collagen together with Alport, which means that thin basement membrane could progress to an end-stage renal disease similarly as Alport. It's not an innocent disease as we previously thought. And a sizable fraction of patients with otherwise uncharacterized chronic kidney disease or those of focal segmental glomerulosclerosis diagnosed based on histology only have a genetic abnormalities in type 4 collagen if if these patients had the genetic abnormality genetic testing. Okay, let's revise. um, capillary lumen should be empty. That's podocyte nuclei, podocyte nucleus, That's a mesangial nucleus. Actually, the mesangial area should be as much as just two cell nuclei, two mesangial cell nuclei, thick, not thicker, not thicker. And as we said, it should have a maximum of three nuclei per mesangial region. Let's talk about tubulointerstitial compartment. As we all know, tubules should be back to back. Tubules could be proximal and or distal. The proximal tubules have more abundant cytoplasm, so they have a narrower lumen, and on the other hand, distal tubules have a fewer cytoplasm and have more abundant lumen. That's an electron picture of a proximal tubule with the peritubular capillaries, BTCs, the famous BTCs in transplant nephropathology. That's proximal with abundant cytoplasm, and that the tubular basement membrane that we said that it is formed of collagen 4 alpha chain also, but 1, 2, 5, and 6, not 3, 4, and 5 as the glomerular basement membrane. And these are the proximal tubule brush borders and the numerous mitochondria. And thank you.
Thank you, Sarah. Myself, actually, I enjoyed your lecture. Actually, it is a very professional, and you explained for us pathology from a different aspect of a different view. I actually attended a lot of pathology lectures, but it is the first time to watch a lecture from this side of view. I actually enjoyed it, and as I see in the chat box, all of the attendees enjoyed it. All of them are thanking you,
Thank you.
and they are waiting for episode 2 from now. The lecture, inshallah, will be. We have questions. Can you take questions, Sarah?
Okay.
Okay. When comparing thickness of glomerular basement membrane,
Mm.
which tubule to compare? To compare glomerular basement membrane to the distal tubule or the proximal tubule?
Actually, what is near, what is more abundant near the glomerular basement membrane are the proximal tubules.
Okay.
These are
So
the more abundant in the cortex.
okay.
Okay.
We have no more questions. All of them are thanking you for the very comprehensive lecture. And actually, I would like to thank all the attendees, because also this lecture wouldn't be successful except by their attendance and their interaction. We will wait for the coming lecture. This lecture, dear colleagues, will be uploaded on NephroTube YouTube channel. Wait the lecture for today, inshallah. We will announce about the next lecture later, bismillah, when we will know the exact date and time, inshallah. Thank
Inshallah.
you, Sarah, again.
Thank you, Dr. Muhammad. Thank you. Thank you very
Salam.
much.
Good night.
Alaikum salam.